Welcome to this OR Live webcast presentation from Wake Forest University Baptist Medical Center in Winston-Salem, North Carolina. Pushing the clinical and academic envelope is our mission here at Wake Forest Baptist. Ranked as one of America's best hospitals in U.S. News and World Report, we bring together the best of patient care, research, and education. Our faculty members are internationally recognized as leaders in their respective fields, and our patients receive the benefits of their medical knowledge and expertise. We provide patients of all ages with top-notch medical care, often reaching beyond the walls of the medical center to help members of the community maintain healthy living. Teaching and learning are the mantra our physicians, surgeons, and healthcare professionals live by, truly showing that at Wake Forest Baptist, knowledge makes all the difference. Patients with lung cancer are now receiving a new advanced treatment option at Wake Forest Baptist Medical Center. The new therapy results in fewer radiation sessions and returns patients to routine activities faster than standard radiotherapy. It is called Elekta Axesse, image-guided linear accelerator. Physicians at the Comprehensive Cancer Center now use this advanced technology to treat tumors and lesions with highly accurate radiation targeting.
I'm Dr. James Urbanic, Assistant Professor of Radiation Oncology here at Wake Forest University Baptist Medical Center, and thanks for joining us on our webcast today. I'm here with Dr. Carnell Hampton, who's one of our medical physicists, and we're going to be walking through our stereotactic body radiotherapy treatment program using the Elekta Axesse machine.
Doctors Urbanic and Hampton work in multidiscipline care teams. The teams assess the healthcare needs of each patient to determine the best therapy. Therapy options include radiation, chemotherapy, surgery, or a combination. For patients with lung cancer, liver tumors, or spinal cord area tumors, radiation therapy with Elekta Axesse may offer significant improvements over current conventional options.
For our patients with lung cancer and even early stage lung cancer where they just have a tumor in a small portion of the lung, that they have multiple other medical problems, breathing problems, heart problems, or other medical problems, severe diabetes, those sorts of things that really preclude them from going to the operating room and having a major lung resection done. And for those patients, our ability to try and treat as small an area of the lung as possible with a very high dose of radiation that's potent enough to control the tumor provides them with a good treatment and a good chance of controlling that tumor.
Cancer patients who are candidates for radiation therapy start with a visit to Dr. Urbanic and his oncology team. The team compiles a detailed medical history, conducts a physical exam, and reviews with each patient the risks and benefits of the best therapy options. The patient returns in 1 to 2 weeks for a planning session to prepare for the selected therapy.
They come back and actually do the planning process where we create the immobilization device that's going to keep them in the right position, get the CT scan done. That really is the basis for our treatment targeting and defining the target in the normal tissues, any other imaging that we need done at that time.
It's great. How you doing? Carnell Hampton. I'm one of the physicists. I'm going to be assisting the ladies in getting you set up today. All right? Got a 4-inch for his head. So we're beginning the process of creating a custom immobilization for our patient.
I'm Bill Kearns. I'm also
He is made to feel as comfortable as possible because we want this to be a reproducible position. We don't want to create any position that's uncomfortable for the patient because he won't be able to replicate that when it comes to his treatment. So the team here that's assembled will just begin to size up our patient, and the patient is lying on this blue bag. It's kind of like a bean bag. But what we'll do in a moment is we will remove the air from that bag, and by doing that, it will take the shape of our patient, making a custom molded pillow for that patient so that he will be able to come back to that same position when it comes time for his treatment. So now the patient's going to raise his arms up above his head.
Are you able to your arms look like up above your head? Relax your shoulders at all anymore? Is that it? Okay, that's fine. You can definitely do that.
And in a moment, we'll form the bag around that patient, and we try to get the patient as straight as possible as well. That just allows us to be centered in the middle of the bag and be able to create a reproducible position. So right now we're going through the process of making that bag custom to him. We'll push air into the bag, which makes the bag soft around the patient, allows him to kind of sink into it, and it formed to his shape. And in a moment, we'll evacuate the air out of the bag, and at that point, it'll form to his shape. And this bag can hold that shape for about 6 weeks. The air is being evacuated from the bag. It's forming to his shape. We'll let it go to there's a pressure, certain pressure, and then when we do that, we'll seal the plug, and basically the bag will stay in this shape for the duration of this patient's time from this point to the end of his therapy. So at this point, our patient is relaxed and is in his treatment position, and again, the comfort of the patient being the most important thing, so that they can hold this position for us for their treatment. Now that we've finished designing the patient's custom immobilization, the patient is ready for CT scanning. So this patient is actually going to get a couple of different CT scans. The first one is a helical CT scan that is the basis of our treatment planning. The second scan this patient is going to get is a 4D CT scan. That CT scan takes into account the temporal information, how his tumor moves, so that we have an image data set that reflects that. That information is useful for treatment planning, such that we are able to make sure we're targeting the tumor as it's moving. We have the totality of that movement incorporated into the treatment plan. So with this 4D CT scan, there is a small marker that is picked up by an infrared camera that allows us to watch his abdomen as it moves with his breathing, and then is able then to tag the movement of his tumor as it's imaging the CT image. And with that, then we have a movie of how that tumor moves while he's being imaged, which reflects how that tumor moves when the patient's breathing freely. So again, with this scanner, this image acquisition will take literally a minute. And we'll have all the image data that we need then to proceed for treatment planning. So at this point, the patient will be sent home, and all the treatment planning will happen over the course of about the next few days, and such that we'll create that treatment plan in consultation with the physician, the physicist, and the dosimetrist. And once we've got a plan that we feel delivers the radiation prescription, then that patient will be called with an appointment for his treatment, and he'll have his first treatment on the Axesse linear accelerator.
All right, so what I'm going to do now is basically center the machine when we do the treatment planning onto where the actual tumor is. And so we've got a 3D reconstruction of what the patient looks like. I can go ahead and look at an actual X-ray image of that. And then in terms of where this tumor is in the patient, this is his right lung here, this is his left lung here, and this is the tumor within the right lung here. And you know, on all views of this, from a slice of bread view or an axial view, a front view of the patient, and then a side view of the patient, I just make sure that I'm centered right in the middle of that tumor. And I'll go ahead and move the center of rotation of the machine to that spot. And I just make sure we're all lined up. And then I'll actually transfer that information over to the laser markers in the room, so that they can then mark it on the patient and have a reference point to where we start our planning from.
So the coordinates come to this computer, or we will enter them. Positive 163.
Dr. Urbanic has set a reference for where his tumor is. We can mark the skin surface of the patient as a reference mark, a sort of an X marks the spot, so that when we come for treatment, we'll have an initial position, a rough position, which we can set the patient up for his therapy.
What we're looking at here is the respiratory motion of his tumor, and we can actually look all through where the tumor is in relation to the lung and really get a picture of how much this is moving with respiration. And in this way, when we go ahead to target this area with the radiation beams, we can make sure that we're not missing his tumor at any point during his breathing cycle. His tumor is this area right here within the lung. So this is his right lung here, and this is his left lung over here. And so the way I look at this image is, although the patient is laying down, we can think of it as he's standing in front of us here. And so his right side is this side of the screen. And so here's this right lung tumor that we're going to try and treat with radiation treatments. He's previously been seen by a thoracic surgeon as well as a interventional radiologist about other treatment options for treating this spot here. This is a reconstructed X-ray image from all the CT images that we've taken, and we've gone ahead and positioned the center of where the machine rotates around, which means the center of our target right within the tumor itself, which is what I'm looking at here on this other slice from the CT scan. This area right here is the tumor from a slice of bread view or an axial view. From a front view, or we call a coronal view, this is the patient's right side of his body. This is that tumor within the right lung here. And then if I look at it from the side, I can see it from this view here as well. And so what I'll go ahead and do is actually contour this tumor on these different views, and then we'll go ahead and use these images to design the radiation treatment plan. And just draw this in. We spend a fair amount of time
doing computer animation work, basically.
Doing this, exactly. So it's a bit like doing some engineering computer-aided design, and right now I'm just kind of roughing this in, and I'll fine-tune this with the motion imaging, and then as I sort of look at it over the next few minutes.
Fabulous.
And so that's basically what I'm going to make sure that I'm doing, is defining this entire tumor right here. This is the part of the process where we really start a lot of our treatment planning in terms of deciding where the beams are going to come from and go to, and where the radiation dose is going to go. Before it even gets over here to this computer system, we've already done a lot of work on these images. We've incorporated all of the motion imaging that we were talking about earlier to see how these tumors move with breathing. We've also incorporated any of the PET scans or MRI scans that we use to basically decide where the target is, the tumor is, and where the normal structures are that we can't define as well with the CT. So that probably represents several hours of work already. At this point, we're looking at an axial CT slice of this patient, and so he's basically laying on the treatment table. It's a little bit hard to see, I think, but this is the bag that he's laying in. You can see there's actually a blanket over the top of this person, and so this is a slice of bread through them. And I think of the feet being towards me and his head being inside the screen there. And so this is his right lung on this side over here, and this is his left lung on this side over here. And he unfortunately has this tumor here in his left lung that he's seen a thoracic surgeon about. Based on all of his other medical problems and the fact this is cancer that spread from another site, it didn't seem reasonable to take that out, and we're going to try and treat this. He also has a tumor on the other side, which we'll look at in a minute. The other normal things that are right here on the screen are his spinal cord, which sits down in this location here within the vertebral body. And then he also has his esophagus over here, and then his main airways. Here's his main stem bronchus branching into the smaller bronchial tree here on the left, and then the large airways here on the right. This is the descending aorta here, so a large blood vessel right here. So there's, in addition to his lung, there's a lot of fairly valuable real estate right in this area, which means that we want to have a treatment that's going to be accurate, precise, and also minimize the dose to some of these other structures. So what we've done here basically is we've defined the target based on the imaging study with motion, and that's this blue area here. One of the other things that we'll do is, even with all of our precision, we'd like to try and prescribe to a little bit of a safety margin around that tumor to make sure that we're going to get all the dose where we want it to go. And so that's this lighter blue color. You can see now it comes around the outside of that actual tumor. And if I turn what we had originally contoured back on, you can see that the actual area that we're trying to treat is this darker blue area in the middle here. One of the things that we work on is looking at the radiation beams and where they come from and where they go to. And this plan is going to be fairly complicated. I've just turned on all of the beams that we're going to use. And there's a tumor over here that we'll look at in a minute. It's a little bit farther down. It's over here, similarly contoured in dark blue to where the tumor is, and this lighter shade is going to be our safety margin, our planning target volume, and then this tumor that's a little bit higher up. And so each one of these lines here represents the edge of the radiation treatment field for that particular beam. And so we evaluate each of these and try to come up with a beam arrangement where we minimize radiation beams coming through important normal structures like the spinal cord or the esophagus or the heart, and take advantage of geometry that minimizes dose to these structures here. We can look at this in multiple different directions to make sure we're coming up with the ideal beam geometry. You can see for the smaller tumor on his opposite side, we have beams that are coming in from closer to the patient's head. This is a side view of the patient here, or closer to the patient's feet. So we can use beam geometry from a number of different directions. And where all those beams crossfire is what we're going to be treating here. The front view is a little harder to get to appreciate that, but you can see that there are going to be beams coming from the side of the patient over here. There are beams that are going to be coming from the front in other angles. And then the beams that are coming from other directions, slightly above and below, are a little bit harder to see on this view here. Once we've decided on that, and this all takes a long time for the person who's a dosimetrist who's normally doing this work, I'm sort of working with them to make sure that we're achieving what we want to achieve, and it's actually not me doing all of this technical work. There's a group of professionals that do that. We'll go ahead and actually prescribe the radiation dose to this tumor, and the way that we do that is we'll go ahead and use each of those beams and turn on the dose to that one, and then to this other one over here we'll go ahead and turn on what we tried to do to that one as well. Okay, so some of this is just computer work, and now we've added more information to what we're doing here. And this, as I had said before, takes a lot of time to do, but I'm sort of going through it rather quickly. And then we'll go ahead and evaluate how this actually looks on the patient and try to make some decisions about what we're trying to treat and what we're trying to miss. This is a little bit like looking at a weather map, where if you have barometric pressure lines on an old-style weather map, the higher pressures are in the inside, or the low pressures, depending if it's a high or low. Well, right here, the higher radiation doses are going to be in the middle. So these lines that are close in here to the tumor are higher doses, and as we go farther and farther away from the tumor, the amount of radiation dose gets lower and lower. For this particular situation, because of the proximity to these major airway structures here in the middle of the chest, is we're being relatively conservative in terms of our dosing for this type of treatment. We're actually treating the patient over the course of 10 treatments to try and minimize our chance at injuring him here with these main airways. And so we're going to give him a dose of basically 5 gray per treatment for the course of 10 treatments, to a total of 50 gray. And that 50 gray line happens to be this red line that you can see is getting around the area where the tumor is prescribed to, and then the dose falls off quickly. This orange line here, which I think is reasonably important, represents the 3 gray line per fraction, or 30 gray for the total dose, which is probably hopefully a reasonable dose to be giving to some of these central structures here. We had a long talk with this patient about some of the risks of treatment, including damaging those structures and the impact it could have on both life expectancy as well as quality of life and his breathing function. And so basically I look through all of this and make sure it looks correct. I also evaluate very carefully doses to the esophagus, which sits here in the middle of the chest, as well as the dose to the spinal cord over here. And of course we can adjust the contrast of this image to look at different things in the chest. And just very quickly to do that, by changing the contrast, I can see the esophagus a little bit better. I can see the area where the spinal cord is a little better. I don't get to see the lung tissue quite as well, or these bronchioles, but as I look at other things, I adjust what I'm trying to do. As we go down a little bit farther in this patient, and then I'll just slide the imaging over a little bit, I'm looking at this other tumor over here, and here I have to worry a little bit about, or actually quite a bit about the heart. I'm trying to minimize dose to the patient's heart as well as dose to the patient's esophagus, which sits right over in here. And we've basically done the same process where we're trying to get the prescribed dose around the tumor and the safety margin and then minimize dose to things like his heart and his esophagus to make sure that we're doing this safely. This area over here, because it's smaller and a little bit further away from some of these main structures, we're going to treat in 5 treatments to a dose of 50 gray. So instead, this time we'll be doing 10 gray per treatment over here. And then we also go ahead and we'll look at this from all the different views. This is the side view of the same patient. We'll look at that smaller tumor down here in relation to the other structures, and then we'll look at the larger tumor over on the other side over there in relation to the other structures. And then sometimes the front view is helpful also. And so we can see that if this is the heart sitting here in the middle of the chest, and this is that smaller tumor, we're pretty successfully keeping away from that. We're getting some dose to the heart from this larger tumor, which is always a challenge with larger structures to limit your dose. But again, I think this dose is fairly conformal around the target, and we're minimizing some of this dose to the middle airways and trying to be somewhat conservative when we're doing that. So what we do at this point is the dosimetrist and myself, we evaluate this. I'll actually approve this. We'll print out pictures of this, and I'll go ahead and approve his prescription and make sure everything's where I want it to be. And then this will actually now go back over to the physicist, Dr. Hampton, and his partners, and they'll go through and make sure that what I've decided to do is technically achievable, that it makes sense in terms of what the machine can do, and that all of the doses are being calculated correctly, and that everything is exactly as perfect as we can make it. And that actually can take a day or two to do that portion, and then we'll go ahead and schedule the patient to come on and get in his treatment. So although this seems quick when I'm doing it here, this whole process can take anywhere from a few days to a couple of weeks to do this. This plan here for the dosimetrist who was working on probably represented easily, with all that was going on here, 8 to 12 hours worth of work. Plus there were some other things going on with this patient as well that took a lot of time as well. So it's a pretty complicated process, and it's not just me sitting here doing this, it's a whole team of people that make this happen. We're going to watch the Elekta Axesse machine essentially be demonstrating a treatment for us. The first thing we're going to look at here is the CT portion of the machine, shine an X-ray beam on the patient, and then spin around the patient. And in this way, it's going to generate a CT image that we can use to target the tumor correctly. And then we're going to look at the actual treatment machine, and that's the upper portion just above the patient there. At this point, we're going to look at the treatment couch, which is a precisely moving table. It's robotically driven, and it can move essentially in any different direction that it needs to. Patients of almost any different size can sit on this table and lay on this table. It's fairly comfortable, although certainly hard and flat. The table itself moves side to side, up and down. It rolls from side to side and forwards and backwards. And in that way, it allows us a lot more freedom to make sure that we're hitting the target, which is the tumor, and trying to miss everything else. To do a lung treatment, a patient that we're going to look at here and with some animation would be laying on the table and positioned very precisely. And at this point, we would obtain a CT image with the actual treatment machine itself. It rotates around the patient, and we can use those images to target the tumor precisely. Once those images are obtained, the machine is going to rotate into the correct position to actually deliver a radiation beam. And you can see that the table will rotate as well. Our most common treatment is what's called SBRT, or stereotactic body radiotherapy. And commonly this would be in the lung, like we're seeing here, where multiple beams can come from anywhere from 7 to 11 different directions. By having so many different beams, we deliver a high dose to the tumor itself and minimize the amount of radiation going to other normal structures nearby, which you can see demonstrated here.
On treatment day, patients go to the Elekta Axesse room and lie on the immobilization bag prepared for them during their previous visit. A therapist and physicist position the patient and their immobilization bag so that they are properly aligned to match the dosage radiation treatment plan.
We're getting set up here to treat our patient today. He's an elderly gentleman with a stage 1 lung cancer, and what that means is he has a tumor just within the lung itself and no other lymph nodes involved. And the goal of treatment for him for a stage 1 lung cancer is essentially we're treating for cure. Our ability to control tumors such as this with higher doses of radiation that we're using commonly nowadays with this type of machine or others provides for upwards of 85 to 90% chance at controlling that tumor. A patient with this stage of lung cancer doesn't require chemotherapy, so the radiation will be the only treatment that he gets. And our hope for him is that he won't have a recurrence at this spot, and in the future, as we do scans about every 3 months, that we won't see anything new come up at that point either. And what we were just doing was basically starting to take a CT image on the treatment table so that we can begin to line up the tumor correctly in order to make sure we're hitting the tumor with the radiation and trying to miss everything else around it. They're trying to look to make sure the position of the tumor and the spine and the big blood vessel in the middle of the chest, the aorta, are all in the right position. And then they can actually manually adjust it a bit, which they're doing now, and the treatment can be adjusted to roll the patient by a degree or two in either direction, pitch the patient a little bit if they need to,
0.96.
and move the patient back and forth.
0.51.
So what we're doing now is
359.3.
translating those positions into the computer system that will automatically move the patient with the robotic tabletop into the correct position to do his treatment. And once they do that, they'll actually move the table position. We moved by about a centimeter at the most, so it's not something that is easily seen sort of visually, but that's sort of the precision that we're looking for. And we rotated him by, looks like about a degree in terms of his rotation from side to side. CT scanner, that's a part of this treatment machine, basically will re-rotate around the patient now we can confirm that the rotations and movements that we did with the patient are correct. And for the patient on the treatment table, he's not feeling anything. I mean, he's hearing the machine rotate. His job basically is just to hold still, lay there as comfortably as possible. And the way this CT scanner works is it's actually a single X-ray beam that's actually being shined across this patient towards that flat panel. Those are 2 flat panels that you can see there, and each one of those individual squares is a detector, and then the computer is able to basically reconstruct all of those images together to generate the CT scan that we're going to look at in a second again. So what I'm going to do now basically is look at all the work that they've done and just kind of verify that what I see looks good. What we're looking at is the tumor here. This is basically a picture of the patient from the front, and that looks correct to me. What I'm seeing down here is a piece of the spine. On these images, this is a slice of bread of the patient. And I'm just making sure that the esophagus in green, the large vessel here, the spine, and then the tumor itself all seem to be encompassed within what we're trying to do with the treatment. That X that went by, that's where the machine is actually centered around. And then I verify in the last set of images over here, the side view of the patient. You can see the spinal cord is running right where I would expect it to be. The heart is the purple area. The green's the esophagus. You can see it lines up nicely on the tube that we consider the esophagus. And then as I get over to the side to where the tumor is within his lung, it's going to show up and hopefully be correct. And that's where it is. And this is encompassing the motion of that tumor as he breathes. And I'm happy with that. So we're ready to get started. You all set?
Yes. Thank you. Thank you.
The radiation is going to come from multiple different directions, and where the beams all intersect or crossfire right on top of that tumor is where the high dose of radiation is going to be delivered. We have, 9 beams today?
Patient is actually receiving
7?
7.
7. Yeah. So 7 to 11 beams is a pretty typical number that we use for treatment. And so that was the first one, and you can see how quick each of the beams are. They're actually verifying manually that everything that they see on the computer screen is correct. So we've done about 3 out of his 7 fields. So we're not quite at the halfway point, but we're getting there pretty quickly. The last half of this will take a couple of minutes longer than the first half will, just because we typically will save the table rotations for the end. So Mandy and Valerie have gone back into the room to basically now reposition the table in such a way that the beam's going to come from a slightly different angle and to allow us to do the treatment from that direction. Those devices, I think I had mentioned before, they're arching over his abdomen and pelvic region, are a measurement device that we use, and also he has a compression paddle on his abdomen, which it's not meant to be uncomfortable. It's simply meant to control his breathing a little bit, and it also helps to minimize the motion of the tumor as well as the motion of the patient a bit. But I think he looks quite comfortable laying there. He doesn't seem to really be having any trouble whatsoever. And that's typical. So we're at the last 2 beams already, and you can see how quickly this went. This is the last field that we're doing here, and they had rotated the table essentially the other direction and rotated the gantry down behind the patient. And a few seconds there, and it's done.
3,000 out of 5,000.
Looks good.
And so that was his 3rd treatment, and out of 5, and essentially we're done at this point. So you doing okay, Mr. Hopper? Doing all right? Good. The most common side effect that we see within the few weeks after treatment is some fatigue. Some patients have almost no fatigue whatsoever, and they're just kind of rolling along with their normal life. Other patients can have a bit more of a profound fatigue, but that'll typically get better within a few weeks after the treatment's done. There really aren't any specific medications for that. It's probably in part related to some of the radiation, as well as coming for treatment every day. It's mostly related to the radiation itself. The other side effect that we're watching for in patients is redness of the skin, some tenderness in his chest wall or rib cage. We'll be watching him very closely over the next couple of months and even over the next couple of years to make sure that the amount of scarring that will appear in his lung right around the tumor is appropriate, and adjusting any medications he may need for that as well. I think it's a reasonable way to do the treatment, and it's certainly a short, compact time frame. Mm-hmm. It's going to take, about a week and a couple of days to get all this? Mm-hmm. So, and did you, what were you thinking sort of between when you saw the surgeon and you had to come over to see us here? Were you anxious about it all, or what was sort of going through your mind?
Well, I was concerned that the surgeon was concerned if he had to do it, that it'd be a high risk of getting pneumonia.
Mm-hmm.
Whereas if you do it this way and it's non-invasive, and he was pleased with being able to be passed on to another process that was better than getting cut open, you know.
Yeah, that's the most common reason that we see patients is because the surgeon is concerned about trying to do surgery.
Yeah, you know, I could do it. We had to pull your lungs, your ribs apart, and get to your lung and all this stuff. There's no pain.
We'd like to thank everyone for joining our webcast today here at Wake Forest Baptist, where we did our radiation treatment with the Elekta Axesse unit.
If you have any questions, make sure you click on the Join the Forum, and we'll be happy to answer your questions today and even in the weeks to come.
And just to kind of recap, the typical process to come and see us is your physician would refer you in to see myself or one of my partners. We'd make sure that the treatment was right for you. And then we do the CT simulation and treatment planning process. And then hopefully within a week or so after that, we'd actually begin the treatments themselves. And typically it's about 1 to 5 treatments. It takes about 45 minutes to an hour for each treatment. And then we'd see you back about every 3 months thereafter to see how you're doing. Again, we appreciate your attention today, and thanks so much for joining us.
Thank you for watching this OR Live webcast presentation from Wake Forest University Baptist Medical Center in Winston-Salem, North Carolina.